wanted to say thank you again to everyone for joining us today for our virtual grand rounds. Like I said, we appreciate everyone's patience for the new format, and I'd like to thank you for joining. For the residents only, I'm going to briefly, for about 30 seconds, share my screen so that you can see the QR code. Is everyone able to see it?
Yes, we're able to see it.
Great. So you can get some credit for attending.
This is Amridesh Pandey. Just as a reminder, this is just for the residents, not for the faculty.
Please move on, Mark.
Right. So I would like to introduce our grand round speakers for today. Our first speaker will be Dr. Janaki Sharma, who is an assistant professor for the Department of Medicine at Sylvester Comprehensive Cancer Center. Dr. Sharma earned her BS in comparative literature from Columbia University before obtaining her MD from the University of Kansas Medical School. She went on to complete her internal medicine residency and fellowships in both geriatric medicine and hematology oncology at Montefiore Medical Center in the Bronx in New York. She currently holds board certifications in internal medicine, medical oncology, hematology, and geriatric medicine. Our second speaker is going to be Dr. Waleed Sneij, who is an assistant professor of clinical medicine in the Division of Pulmonary and Critical Care Medicine here at the University of Miami Jackson Memorial Hospital. Dr. Sneij did his undergraduate work in biochemistry and philosophy at the University of Miami. He then went on to earn his MD and Masters of Science from Eastern Virginia Medical School. He did his internal medicine residency and critical care fellowships again here at the University of Miami and Jackson Memorial Hospital, and currently holds board certifications in internal medicine, pulmonary and critical care medicine, and critical care echocardiography. So at this time, I think I will introduce invite her, Dr. Janaki Sharma, to start with her lecture. Thank you.
Thank you, Mark. So I'm going to be presenting on a clinical vignette and some updates on where we stand in terms of prostate cancer treatment and some of the new ways that we're looking at classifying prostate cancer. Can someone just respond and say that they can hear me and see the screen appropriately?
Yes, we can.
Thank you. So I have no disclosures. The objectives of today's talk are to give you an overview of recent developments in treatment of advanced prostate cancer, and to understand some of the different molecular subtypes of prostate cancer and discuss the clinical ramifications for that subtyping. So I'll be presenting two quick cases of patients that I've seen that actually had very dramatically different treatment courses to sort of give you an idea of the breadth of prostate cancer clinical cases that occur. So the first patient was a 76-year-old male that presented to me almost 10 years ago in 2009. When he was diagnosed with metastatic prostate cancer with bone metastases only. His PSA at the time of diagnosis was over 4,000, and he had multiple comorbid conditions, including hypertension, and had previous strokes. He was on a host of medications. But aside from that, was actually a fairly robust 76-year-old gentleman with very little unremarkable in the way of a physical exam. So I started him on treatment with androgen deprivation therapy, which is commonly heard, you guys may have heard of Lupron as one of the common treatments for that. And he actually went on to live for almost over a decade with various treatments for his metastatic prostate cancer. The second case is a gentleman that presented to me much more recently. He was only 66, and he also presented with newly diagnosed metastatic prostate cancer with metastases to his bone only. He had a much lower PSA at the time of diagnosis, only 51. And he had no medical conditions, took no meds, was a construction worker and actively working when I saw him. He had an excellent performance status and an unremarkable physical exam. He was started on the same treatment, but unfortunately, as you'll see later, despite going through multiple rounds of different therapies, he only survived for 2 years with his metastatic prostate cancer. So what I hope to convey to you is that there is a huge breadth of presentation with this disease, and we're just now starting to understand why that may be the case and how we can target different therapies towards that. So as a general overview, prostate cancer is the most commonly diagnosed malignancy in the United States. 25% of new cancer diagnoses in men in the United States are prostate. It is the second most common cause of cancer-related death in the United States amongst men, accounting for about 10% of deaths annually in the United States. The way prostate cancer progresses, typically patients present in the locally advanced stage, sorry, not locally advanced, just a locally present stage. We give some kind of local therapy, which might be surgery or radiation or ultrasound-directed therapy. And then about 95% of the patients will do well and never progress again. But unfortunately for the other 5%, they do start to progress. And at that point, the amount of prostate cancer in their system continues to rise, as you see along this curve. And until it gets to a certain point, either their PSA, which is a prostate secreting antigen in the blood, or we see disease in their scans, gets to a significant level, we start them on castration therapy. So that's either orchiectomies to remove testosterone, or it is Lupron or Firmagon, which are two medications that work on the pituitary hormonal axis to eliminate testosterone secretion in the body. For a time period, that works very well, controlling the prostate cancer, decreasing the disease burden. And then eventually, the prostate cancer develops what we call castration resistant, such that it continues to grow despite there being no primary driver in the form of testosterone. Historically, at that point, the only treatment we had was docetaxel, which is a type of chemotherapy. But now we have multiple new treatments at each of these phases. A lot of these treatments are hormonally directed therapies, and some of them are radiation-directed therapies, some are immune-directed therapies, and some are chemotherapies. I'm going to provide a brief overview of each of these novel treatments, and such that this is probably a better way of thinking about prostate cancer now, this model, which is, clinically localized disease initially, and then patients progress to a form of disease with a rising PSA or metastases. And then we need to do something about it. So we start them on hormone deprivation therapy. And for those 5%, a portion of them will then become resistant to the hormone deprivation therapy and develop castration-resistant disease, which is these yellow boxes. And then these castration-resistant patients now have multiple lines of treatment as well. So the first line of therapy, as I talked about, is androgen deprivation therapy. We now know that adding some of the newer treatments early on helps people to live disease-free and live in general overall for longer. So there is data to support the use of early chemotherapy, which is docetaxel. So these are patients that are initially presenting with metastatic disease, meaning disease that's spread outside of the prostate. We start them on hormone deprivation therapy to get rid of their testosterone. And to that, we would add docetaxel chemotherapy. And remarkably, adding this chemotherapy up front when patients are still in the hormone-sensitive phase actually has a greater than 1 year survival benefit for patients with high volume disease, and almost a little bit over a year benefit for all patients. And this was proven in multiple studies. Also, we have data now supporting the use of abiraterone, which is another drug that modifies the hormonal axis, and I'll go into that a little bit more later. In the hormone-sensitive setting, addition of abiraterone also led to an over 1 year survival benefit for patients with metastatic prostate cancer. And a third agent that we use early on, which is called enzalutamide, also had an over greater than 1 year survival benefit. So bringing a lot of the treatments that we used to use later on in the disease, bringing them up front earlier, has shown a significant survival advantage for patients. So at some point, even after we bring these drugs earlier into their treatment course, patients develop castrate resistance, which is where traditionally just modifying their hormone axis no longer works. And there are several different patterns of castrate resistance that can develop. So the first pattern is where the prostate cancer comes back locally, just in the prostate. And there's no evidence of metastases anywhere else. A second pattern is something called non-metastatic castrate-resistant prostate cancer. So this is a patient that had metastatic disease to begin with. They got their hormone therapy, the disease went away, and now their PSA is rising, but we can't see the disease yet. The third pattern would be patients that have lymph nodes that have developed despite hormone therapy. The fourth pattern is patients that have bone disease with or without lymph nodes. And the fifth pattern would be patients that have disease in the organs. And these are sort of listed in an order of increasing aggressiveness. So for the locally recurrent prostate cancer, the disease that comes back in the prostate are local lymph nodes only. We have local therapy options, including radiation, surgery, or ultrasound, HIFU treatments. For the non-metastatic castrate-resistant prostate cancer, so this is patients that have a rising PSA, but no visible evidence of disease. Our original, until about 2-3 years ago, our only option was to do something called anti-androgen withdrawal, which is where you take away the treatments that you're giving them, and they actually do a little bit better. But since 2018, we now have second-generation anti-androgen drugs that we can use in this setting, which help prolong something called metastasis-free survival. So that means giving these drugs when patients just have a rising PSA, but no evidence of disease that we can see physically, actually helped to delay the time until we had evidence of disease that we could see on scans. And that time was delayed from a year to almost 3 years. So, giving these drugs early on, you are exposing patients to more medical intervention, but there is a significant, more than 2 years in some cases, delay to the time of metastases. Then for the patients that have metastatic castrate-resistant prostate cancer, so this is the patient that's on hormone therapy and then develops a rising PSA and visible evidence of disease. We have multiple new treatments, the ones that we discussed before, really, that have led to a significant prolongation of overall survival. When about 10 years ago, patients that had castrate-resistant prostate cancer, the median overall survival was only 9 to 18 months. And now overall survival in studies is greater than 30 months on average, oftentimes up to 4 to 6 years. So we have a lot of new options, but what's been difficult is figuring out what order to give them in, and also why certain patients respond to some treatments, but other patients do not, despite what are traditionally our markers that we use to evaluate the disease being equal. So the novel hormonal agents that we have, the first one is abiraterone. This is an adrenal steroidogenesis synthesis inhibitor. So it basically works at this part of the axis, preventing the adrenal glands from synthesizing DHEA, which is an androgen, which can also work to stimulate prostate cancer growth by working on the androgen receptor. The other hormonal agents that we use in this setting are called second-generation anti-androgens. This is like the medications enzalutamide, darolutamide, apalutamide. What these do is these basically work directly on the androgen receptor, which is what drives prostate cancer growth. They basically prevent the androgen receptor from binding its ligand and stimulating prostate cancer growth. They prevent the androgen receptor from localizing to the nucleus, and they can also suppress the expression of the androgen receptor. Each of these medications works in a similar fashion, but due to varying compounding differences and mechanistic differences, they have a slightly different side effect profile from each other. In general, they do produce the same overall survival benefit, though, in the castrate-resistant setting, about 6 months to a year. Other newer options, docetaxel, which is a well-known chemotherapy for prostate cancer. Now there's a second option called cabazitaxel. It's a taxane or a microtubule inhibitor type of chemotherapy. It prolongs overall survival for about 3 months in patients that have already received docetaxel. We also have something called radium-223. This is it's a radiation treatment that's delivered intravenously. And it works particularly well for patients that have bone-only disease. It's a calcium mimetic, It's infused, and it is a calcium mimetic attached to alpha particles that have a limited radius of radiation. So they go directly to areas of prostate cancer in the bone and radiate the disease locally. This also has around a 3-month survival benefit compared to no treatment. And then the final treatment that I'll discuss, the novel treatment, is immunotherapy. This is a medication called Sipuleucel-T. It's been around for quite a while, actually, almost a decade at this point. And it works by collecting a patient's immune cells, removing the monocytes, and exposing them to a prostatic androgen phosphate, which sensitizes them to attack the patient's prostate cancer, and then reinfusing those cells, which allows the patient's immune system to become more active against the prostate cancer. A reason that this hasn't gotten widespread adoption is because we don't have a great way to monitor whether this treatment is working or not. Data has been produced showing that it does improve overall survival, but it doesn't actually have a response in terms of the PSA or in terms of the imaging. So it can be confusing to administer and monitor. There has also been work done on checkpoint inhibitors, which are, sort of the new craze in oncology. This is like nivolumab, pembrolizumab. But unfortunately, these medications have not been shown to be very effective in terms of prostate cancer treatment. And part of the reason for that is because prostate cancer is a particularly cold malignancy immune-wise. The prostate is an inherently immune privileged space. It doesn't have afferent lymphatics. Seminal vesicle fluid is sort of inherently immunosuppressive. There aren't many tumor infiltrating lymphocytes, which you need to really stimulate an immune response in the prostate. So there have been some attempts to combine checkpoint inhibitors with cancer vaccines, with other immunotherapies, with radiation treatments, and with other second-generation anti-androgens to try and increase their effectiveness. But so far, most are in phase 1 trials, and those that have made it to phase 2 trials have really not had much benefit. So I want to go back to the cases now that you have a general overview of what exactly are our options available to us. So our first gentleman, the older gentleman, the 76-year-old whose PSA was over 4,000, he had a robust response to his initial anti-androgen Lupron therapy. His PSA was almost 0 for over 3 years on just Lupron alone. And after 3 years, he started to have progression of disease with worsening bone metastasis. So I started him on abiraterone, which is one of the second-generation anti-androgen drugs that we discussed. And he responded to that for another 2.5 years. And then he again had progression of disease, so I switched him to enzalutamide, which is another second-generation anti-androgen agent. And he responded to that for a year before his bone metastases got worse. After that, I started him on radium-223, which is the IV given radiation therapy. And he did 6 months of treatment on that until 2017, which is almost 8 years after diagnosis. And he had no evidence of progression for another 6 months. And actually at the time he died of a STEMI. And his PSA was, I believe, almost 0 at that point. So the 76-year-old gentleman with multiple comorbidities lived for almost a decade with metastatic prostate cancer. My other gentleman, who was 66 and had a much lower PSA at the time of diagnosis, had a less robust response to androgen deprivation therapy. He only noted for 6 months his PSA was low, and it never actually got maximally suppressed down to 0. I gave him abiraterone, and unfortunately, after 3 months, his PSA still did not come down further. I switched him to enzalutamide, which I tried for another 3 months, and he had no response. At which point, we repeated imaging, and it showed that he had progression of disease despite being on these treatments for 6 months, and he had new liver lesions. The biopsy of the liver lesions confirmed prostate adenocarcinoma. So at this point, I decided to try traditional chemotherapy with docetaxel. He got 14 cycles of docetaxel, and then unfortunately, his disease never really responded robustly. He achieved stable disease, but he continued to have significant side effects from the docetaxel chemotherapy and opted for hospice care. He eventually died around 2 years after diagnosis, despite being 66 and having no medical comorbidities at the time of diagnosis. So the question is, what explains why these two patients did so differently despite receiving the same treatment, despite having the same diagnosis of prostate adenocarcinoma? And is there a way to target the drivers of that heterogeneity between the two patients? So there's a lot of research being done into what explains this heterogeneity. And one thing that has emerged recently in the past 3 years is molecular subtypes of prostate cancer. And that's what I'm going to talk about briefly. So this exact cell lineage for prostate cancer is still unknown. Initially, the thinking was that prostate cancer primarily derived from the luminal cells, which are those closest to the acinar ducts in the prostate. But there is mounting evidence, particularly in murine models, to suggest that the basal stem cells can also trigger progression of prostate cancer. And I'm sorry that these are not great resolution, but this is a normal prostate on the left. And you can see this is the traditional architecture of the gland with smooth basal cells, lining, and then luminal cells closer to the ducts. In the adenocarcinoma, you can see that there's a complete distortion of architecture. And although you can see some ducts here, it's hard to tell whether the cells of origin are luminal or basal. So one way we can do this is to use genetic signatures and molecular subtyping. So this type of classification into luminal and basal subtypes has been done in other tumor types, particularly in breast and bladder. And in breast, it's been well validated and shown to have differences in prognosis and response to treatment. In bladder, we're also seeing that luminal and basal subtypes, there's emerging evidence that that can also prognosticate in terms of response and treatment. So in 2017, the first retrospective and prospective analysis of prostate cancer tissue was done, showing that prostate cancer demonstrates gene expression patterns similar to luminal and basal classifications used in breast cancer. So this was a multi-center analysis of almost 4,000 patient specimens in the US and Canada. There were 6 retrospective cohorts and 1 prospective cohorts. And it used something called a PAM50 classifier, which is a well-validated classifier of genetic signatures in breast cancer. And this classifier consistently segregated prostate cancer into 3 subgroups, luminal A, luminal B, and basal. This is the clustering pattern. And as you can see, the luminal A gene expressions are all similar, luminal B, and basal. And the split was approximately even between the 3 subtypes, with luminal A being about 34% of the patients, luminal B 28%, and basal 37%. So they looked at around 1,500 of these samples, of the 4,000 samples that had clinical data, and then correlated these subtypes with the clinical data. And what they found was that overall, luminal B subtypes had a worse clinical outcome for all different measures. So the top left data graph is on biochemical recurrence-free survival, meaning basically patients that stayed with a suppressed PSA. The light blue line is luminal B subtype. And what you see is that fewer patients have biochemical recurrence-free survival that are of the luminal B subtype, whereas luminal A and basal had similar results. The top right shows distant metastasis-free survival. And again, you see that luminal B subtype had a much worse outcome. The bottom left is prostate cancer-specific survival, and the bottom right is overall survival. And again, these are significant, statistically significant differences in overall survival and prostate cancer-specific survival. Luminal B pattern demonstrated significantly poorer outcomes at all endpoints, and there was no clinically meaningful difference in the outcomes between luminal A and basal. This is despite the fact that luminal A had a lower proliferation score, meaning that it's a less rapidly dividing tumor. And the basal proliferation score was actually similar to luminal B, which are the patients that had the worst outcome. Luminal B patterns also had higher Gleason scores indicating more aggressive disease and higher rates of locally aggressive disease in those patients that were post-surgical samples. This shows the similarities between luminal A and luminal B. And this is about the androgen receptor, basically. It shows that androgen receptor expression was strong in luminal A and luminal B types, but not in basal. The traditional thinking was that androgen receptor expression is associated with a less aggressive phenotype of disease because we have so many agents that target the androgen receptor. However, as you saw previously, luminal B patients, despite the strong androgen receptor expression, had worse outcomes than luminal A patients, which had the strong androgen receptor expression as well, but a lower proliferation score. So the question then becomes, despite the fact that luminal B patients have worse outcomes, does having a higher androgen receptor expression affect the way that treatment is going to affect them? So then in the same study from 2017, they looked at whether patients responded to androgen deprivation therapy or not. And it was expected that because luminal B patients had a higher androgen receptor expression, they would have a greater response to androgen deprivation therapy. And that was actually shown. So the most important graph is this one in the top left, which is the clinical outcome of luminal B patients. The blue line shows the patients that were treated with hormone deprivation therapy. And the yellow line shows the patients that were not treated with hormone deprivation therapy. So you see that luminal B patients that got ADT, that got hormone deprivation therapy, did much better than those that didn't. Whereas on the right side, the luminal A patients didn't do that much differently, whether or not they got hormone therapy. So this research has then been looked at in other clinical trials that have shown a benefit to various medications.
2 minutes. 2 minutes.
Looking at the subtypes, this is my last. Looking at how the subtypes might affect response to treatment within these already done clinical trials. So the CHARTED trial, which showed that chemotherapy is great for hormone-sensitive prostate cancer, researchers looked at the gene expression profiling for 160 of those patients and found that for the 50% of tumors that were luminal B, so that's the patients that traditionally do worse with overall survival, they actually had more benefit from chemotherapy than patients that were not luminal B. So this is really, sort of the cutting edge of where we want to go in predicting response to prostate cancer treatments and in choosing which treatments we want to be using first for patients based upon their molecular subtyping. Unfortunately, we're not making clinical decisions based on this yet, but within the next 2 to 3 years, further research should come out helping us, guiding us in choosing the appropriate first-line treatments for our patients. Since time's almost done, I just want to give a couple of minutes for questions.
Dr. Sharma, thank you so very much for the very clear and interesting review of this important topic. We have one question from Dr. Lutsky. Can you comment on the role of PARP inhibitors in prostate cancer with BRCA mutations? Did you hear the question? You're on mute. Dr. Lutsky will be sure that Dr. Sharma sees that question and will respond in writing to you. Thank you very much, Dr. Sharma. Dr. Sneij. Laura, are we getting the next set of slides up? Hello?
Just one moment.
Okay, I'm trying to pull up my PowerPoint. I'm going to share my screen. Are you able to see the share screen yet?
Uh,
There we go.
There we go. Now we can see it.
Okay, fantastic. All right, well, thank you for giving me the opportunity to speak about the cytokine storm syndrome. This is basically a continuation of my colleague Dr. Shafazan's discussion last week on her talk on the pulmonary manifestations of COVID-19, and this is basically a discussion of phase 2, where the immune system becomes dysregulated and causes havoc into the entire system. First off, I'll just say that I have no disclosures. As far as my talk is concerned, I'm gonna wanna organize it in 3 phases. The first section of the talk will talk about the phases of COVID-19 as far as a way to conceptualize the course of the disease, where you have a viral response phase as the initial phase, and then you have a host inflammatory response phase, which will be the focus of my talk. I will also present a case which will facilitate the discussion, and then finally we'll talk about cytokine storm syndrome definition, potential therapies, and rationale for treatment. So this here is what I find to be helpful. This is a graph of basically the course of the expected course of the disease of COVID-19. You may have seen similar graphs in other social media postings, and this is was recently released just maybe a week ago, where the disease severity correlates with basically the cytokine response. And where you have in the initial stage, you have a stage 1 where there's early infection. This may be the asymptomatic patient, or a patient with mild constitutional symptoms with mild fever. Stage 2, Dr. Shafazan discussed last week, and this is the pulmonary phase. Stage 3, pulmonary phase, where you have some shortness of breath, some hypoxemia, there is some abnormal chest imaging, the collateral infiltrates that the classic presentation of COVID-19, some transaminitis, and basically stuff that we're already familiar with. Stage 3 is where the host inflammatory response phase becomes the main driver of morbidity and mortality. Here we developed ARDS, or a state-like ARDS, shock and cardiac failure with myocarditis, as some of our cardiology colleagues have already described. The inflammatory markers are sky high, and this would be also a focus of our talk today. So as far as the case presentation, the patient that came in a few weeks ago, this is one of the first patients that I and our division have admitted with severe COVID, and to the point where she did develop cytokine storm. She's a 41-year-old woman with a history of postpartum cardiomyopathy, basically, and also a history of morbid obesity. She's presenting with typical presentation of COVID. She had some exposure. This was before the social isolation initiative, and before restaurants were asked to close and only give deliveries. Her exam, typical presentation again, a little bit. She had hypoxemia, she had tachypnea, and what was most worrisome, besides her comorbidities of cardiomyopathy and morbid obesity, she later developed some somnolence in the emergency department as she was waiting for admission, and the blood gas showing a acute component of a chronic respiratory acidosis. X-ray typical with or consistent with COVID-19. In her case, she has low lung volumes as well, and she has a history of, it looks like she has a history of elevated left hemidiaphragm, which further compounds the problem for her. As far as additional data for her, overall, initially when she presented, lab values were only remarkable for some markers of inflammation, CRP being 2.1, IL-6 being elevated at 43. So if we were to fit her into this timeline, she would be in the obviously the pulmonary phase, maybe in the latter part of 2B, where the viral response phase is tapering off, and now she is starting to have a host inflammatory response. And this is probably once we recognize this is going to change our management, and we'll talk about that very soon. So when she first came to the ICU, we intubated her without real complication. She did desaturate, but she came up pretty quickly after intubation. We started her with typical hydroxychloroquine, azithromycin, ceftriaxone cocktail empirically. This was a time when the PCR took a few days to return. And as you can see, there is a very significant hypoxemia post-intubation with her PDF ratio is 102, which is very well near the severe ARDS range. In any case, we know how to handle this. This is in our experience, hypoxemia is something we handle just fine. Give her supportive care, make sure we don't damage her lungs with iatrogenic injury, give her diuresis, and sure enough, days 2 and 3, she responded as we hoped. Her PEEP went down from 18 to 15, FiO2 requirements went down, and the next day you had that same pattern. Right on by day 3, the FiO2 was at 50%, and her P to F ratio doubled to approximately 207, which is good news. However, knowing that this likely is COVID, and learning from the experiences from our colleagues in Italy and in China and the rest of the world, we know not to keep or let our guard down. And sure enough, our urine output did go down, inflammatory markers went up, and again, we were aggressive in trying to make sure that we kept her volume negative, and we started ultrafiltration after a hemodialysis catheter was placed. We knew that a storm was coming, and sure enough, we did have inflammatory rising on the 3rd day, and pressure requirements nearly doubled. FiO2 for real no reason except for the cytokine storm worsened to almost 90%. And at this point, we started paralytics. And at this point, we started immunomodulation with tocilizumab with the help of our infectious disease colleagues. On the next day, whether this is coincidence or a reaction or response to the medication, her levothyroxine requirements went down to 12. And again, from a 90% FiO2 down to 60%. So again, some good news, but this is going to, you'll see that this is a rocky, a roller coaster for a lot of our patients, and she's no exception. By the next day, all pressures were off. And what seems to be a calm after the storm really is just the eye of the storm. By hospital day 6 and 7, while the pressures were off, oxygen requirements worsened. She went from 0.8 to nearly 100% of FiO2 shortly after. And we have had difficulty with ultrafiltration. The system was getting clotted. There's a lot of talk of microthrombi, and there's research ongoing about what's going on there. Anyway, as far as her hypoxemia, she was prone on hospital day 7, and the pressures that were previously off, now they're at 30 mics. She continued to worsen. We tried to supinate her, but that was not possible because she desaturated almost immediately, and we had to reprone her. And pressure requirements continue to go up. Again, with collaboration with our infectious disease colleagues, we decided to. This is a point where immunomodulation and immunosuppression probably would help, and so we started high dose steroids. And we gave plasma exchange, and IVIG was given as well. This is just a graph or a chart of some of the inflammatory markers that peaked. Some of the notable ones, D-dimer greater than 20, which I don't have a full quantification of, but it went from 1.61 to greater than 20. LDH at 3,400, IL-6 from 43 to 4,800. Fibrinogen dropped to around 160, and ferritin did go to around 900. Although not sky high, it's still greater than some of the cutoffs that we'll discuss very soon. So again, we are now at stage 3, the hyper inflammation phase, and where the host inflammatory response phase is the predominant driver of the morbidity that we're seeing in our patients in the ICU. This is again characterized. The characteristics include ARDS or ARDS-like features, shock, and cardiac failure. What is happening? So we have a degree of hyperinflammation, obviously. In COVID-19, we have a lot of markers that are sky high, including interleukin-2, interleukin-7, monocyte, chemoattractive protein, a very complicated cytokine system that is currently under a lot of research. And as an intensivist, and clinicians out there, we often ask, so what? These cytokines are expected to be high. This is a state of inflammation. Patient is in shock. We expect these things to be elevated. But in reality, the understanding and the consensus is that this is not an appropriate response to the infection. There's a breakdown of regulation. There's hyperinflammation that is counterproductive, and there's associated high mortality with this syndrome. This graph, this diagram delineates some of the downstream effects of the cytokines, including endothelial dysfunction and a sepsis syndrome, hypotension, and some fibrotic changes in the lungs. As far as what exactly is happening, it's not fully understood, obviously. Again, there's a lot of research undergoing in this particular field. What exactly might be happening is that we know that the ACE2 receptor is involved in innate immune modulation. And so with the virus binding to the ACE2 receptor, either directly or indirectly, it is a mediator of inflammation right there and then. Also, there's a possibility of an underlying genetic predisposition that is unmasked by the virus. And so, while most people do fine, they don't get cytokine storm. There's a select subpopulation where it is a problem because of genetics. And there's other research delineating defects in granule-mediated responses, which causes a deficiency in cytolytic activity, and because the inflammatory cells are unable to kill their target, there is persistent activation of these inflammatory cells, and you have a downstream effect or a domino effect. However, as an intensivist, as other specialties of medicine, we've seen this before. Dysregulated host response to infection causing life-threatening organ dysfunction. That right there, while it describes what we're seeing in the ICU with COVID, it also is the very definition of sepsis 3.0, or sepsis 3 rather. So the question now is cytokine storm syndrome a separate disorder, or is it an extreme form of the sepsis spectrum? Furthermore, this syndrome is recognized in other specialties. Dr. Sharma in oncology, and we have our colleagues in rheumatology and hematology and infectious disease. A syndrome like this is something that they deal with on what could be a regular basis. The nomenclature can be confusing. So what we're calling cytokine storm syndrome, we're trying to see if this fits with other models that have similar syndrome, that have a similar syndrome. So in intensive care, we see this and we recognize this as a multiple organ dysfunction syndrome. Rheumatology recognizes this type of pattern as macrophage activation syndrome, and in oncology, this pattern could be called hemophagocytic lymphohistiocytosis. Again, very confusing, and I want to kind of delve into HLH just to use this as a model for what we're seeing in cytokine storm syndrome. So in primary HLH, this is a genetic disorder of the immune regulation presenting in neonates. Excuse me. In secondary HLH, this is an acquired immune hyperactivation from dysregulation of the immune system. You have fever, hepatosplenomegaly, cytopenias, liver dysfunction, hyperferritinemia. Again, this is seen in autoimmune disorders, malignancies, and infections. This can look like sepsis. While the patient may be in septic shock, or rather in some sort of undifferentiated shock, it looks like sepsis, but there's no infectious organism present. Maybe it's an autoimmune disorder leading to a sepsis mimic. And then you also have an infection that can lead to HLH, which further causes confusion. Here is a slide that shows a macrophage, an activated macrophage, having already engulfed a banned neutrophil and some RBCs and platelets. This process causes cytopenias, causes hepatosplenomegaly, and lymphadenopathy in HLH. Quickly, as far as causes, we already talked about some of the infectious causes, and these are more specific entities: Epstein-Barr virus, herpes, HIV, influenza, very notable. Some strains have been shown to cause this. Parasites, fungus. As far as diagnostic criteria, this is well delineated in our rheumatology specialties. Whether either a molecular diagnosis can be made, or you can have, because this is a syndrome, you can get 5 out of the 8 of the following features, which we'll talk about very soon. This is further simplified with an H score that can be plugged into a MedCap calculator online. And again, some of the features we'll describe very soon. Now, we have to make the case on whether or not this is compatible, or can this be extrapolated to COVID-19. If you have from having HLH to COVID-19, is there a similar pattern? And the answer is, for the most part, yes. So you do have fever, you do have anemia, thrombocytopenia, neutropenia. We are seeing hypertriglyceridemia, hyperfibrinogenemia. We are seeing hyperferritinemia, elevated soluble CD25. We are seeing some liver dysfunction, and what remains to be seen, or based on this graph, is splenomegaly, hepatomegaly, and hemophagocytosis. However, there is recent evidence based on autopsies in China where there is splenic atrophy. So this is different than HLH. We don't have splenomegaly, we have splenic atrophy. And also you have atrophy and necrosis of lymphoid tissue. And there have been activated macrophages undergoing phagocytosis seen in the spleen, although the article that I reviewed did not mention if this was hemophagocytosis or regular phagocytosis. As far as the rationale for treatment, so we know that the virus is causing initial damage. So obviously there's a role for antivirals if we have them. And we're making the case now that the dysregulated immune response is causing additional damage. So logically speaking, the rule for immunosuppression and or immunomodulation is expected. There is prior research. So we know that immunosuppression is helpful in the right population, in the right timing. It is harmful otherwise. As far as prior research, we have shown, there have been studies that show that steroids improve mortality in septic shock if cytokines were significantly elevated. If they were not elevated, then mortality actually increases. classically EBV-related HLH, there's improved survival with early treatment. And then IL-1 receptor antagonism that is used in septic shock in the right patient population improves survival. That patient population includes patients with hepatobiliary disease and DIC. So very quickly, this is a Kaplan-Meier curve showing that a survival benefit is seen when steroids are given in the right population in septic shock. So here, this is so here you have the Kaplan-Meier mortality curve or survival curve, where the cytokines were low and no steroids were given, and the mortality is highest here. Excuse me, the survival is highest here. Let me draw attention to this red line, where yes, this red line here, where the septic shock or cytokine storm is happening and no steroids were given. You have a dismal survival. However, if steroids were given, you have an improvement in survival. Again, this only is seen if there is a elevation of cytokines. If you give steroids in a patient that does not have elevated cytokines in septic shock, you have increased mortality. Classically, this is also seen, we see benefit in EBV-related HLH treated with etoposide. This benefit is only seen if the treatment is given early. The benefit is not seen if the treatment is given late, and to the point where it is the same mortality as if the patient was not treated at all. Lastly, this is a recent study that showed IL-1 receptor antagonism. Given the right patient population, somebody who has hepatobiliary disease, you go from a mortality reduction from 65% down to 35% with treatment. As far as potential therapies for cytokine storm, there are many. Again, this is currently undergoing lots of research, and it's vastly needed ASAP. Back to our patient, we can make the argument that she is out of the viral phase, and she's been in the host inflammatory phase for a while now. The question is this the tail end? Reviewing her chart, I've been off service for a day or two. There is a period of plateau currently in her case, and at this point, so a period of plateau meaning she's not getting worse, she's not getting better, and so this is the point where we exercise patience. Continue good supportive care, lung protection strategies, especially avoiding iatrogenic injury, very, very important. Continue proning whenever is indicated, diuresis, and reduction of infection risk by removing unnecessary lines, etc. So as far as final thoughts, so not to state the obvious, we need more evidence. There are currently RCTs being planned. Perhaps some are currently undergoing. We have some colleagues in our division that are currently drawing up plans for some RCTs. Regardless of the treatment strategies, standard supportive care is paramount. So I make a big effort in terms of teaching and in terms of residents and fellows, as far as iatrogenic injury is something that something we really need to avoid. And so placing the patient on the ventilator is not a benign process. While it will help the patient breathe, obviously, and it may save the patient's life, we have the potential to cause a lot of injury to the lungs if we don't properly monitor the pressures and the volumes. From this talk, I want to make the case, or I hope I have made the case, that it is very important that we monitor for cytokine storm so that we can prognosticate and evaluate for potential treatment options in these patients. This can be done on the floor with our hospitalists and our residents, anybody who is being admitted to the hospital. It's very important to monitor the inflammatory markers. and then finally, again, I want to just reiterate, this is not something that is totally new to us as a division or as a department. Rheumatology, infectious disease, oncology, critical care, we've seen this pattern of cytokine storm in various disease processes. And we've developed some very effective treatments in the past for those particular disease processes. Question is whether we can extrapolate that experience to today, and I hope that is definitely the case, and we're currently working on that. So with expertise throughout all these specialties, I think we will get through this pandemic together. I'll pause here, or actually I'll finish here. If there's any questions, I'm happy to answer them.
We will get through this together, Dr. Sneij, with you and your colleagues and all of us together. There are very good questions that are on the chat. I'll be sure you get copies of those. And if you could please answer them so we can distribute them to the faculty. It's 1 o'clock. I want to wish everybody a good day. We do have a faculty meeting this evening. Those of you that can join, terrific. If not, we'll certainly get the information to you otherwise. Thank you for both our presenters, Dr. Sharma and Dr. Sneij. This was a great grand rounds, and everybody be safe and be well.
Thank you. You too. Ah!